Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 365 of our pharmacotherapy series, which majors in acid-base disorders. The next case reads, G.D.Y, a 64-year-old, 60 kilograms man, is brought to the emergency department by his family in a semi-comatose state. He was found lying on the floor of his garage near a partially empty bottle of windshield wiper fluid 30 minutes ago. G.D.Y has a long history of alcohol abuse and recently diagnosed dementia. In the emergency department, supine blood pressure is 120 systolic 60 diastolic, pulse is 100 beats per minute, and respiratory rate is 40 breaths per minute. G.D.Y's pupils are reactive, and mild papilledema is noted. Laboratory tests reveal the following: serum sodium levels of 139 milliequivalents per liter. Potassium levels of 5.8 milliequivalents per liter. Chloride levels of 103 milliequivalents per liter. Blood urea nitrogen of 25 mg per deciliter. Creatinine of 1.4 mg per deciliter. Fasting glucose of 150 mg per deciliter. His ABG include pH of 7.16, partial pressure of carbon dioxide of 23 mm of mercury, and bicarbonate of 8 milliequivalents per liter. His toxicology screen is negative for alcohol, and his serum osmolality is 332 milliosmoles per kilogram. So my question to you reads, what acid-base disturbance is present in G.D.Y? And what are possible causes of the disorder? G.D.Y has an acidosis since the pH is 7.16, and he has a bicarbonate of 8 milliequivalents per liter, with a large anion gap of 28 milliequivalents per liter. Subtracting 10 from the anion gap of 28 and adding this value to his serum bicarbonate concentration yields a value of 26, suggesting no other metabolic abnormality is present. An elevated anion gap metabolic acidosis often indicates lactic acidosis resulting from intoxications, e.g., salicylates, acetaminophen, methanol, ethylene glycol, paraldehyde, or metformin, or ketoacidosis induced by diabetes mellitus, starvation, or alcohol. Step 6 in the stepwise approach leads to the consideration of additional laboratory tests that may be helpful in the differential diagnosis of an elevated anion gap. These include serum ketones, glucose, lactate, BUN, creatinine, and plasma osmolal gap. Osmolal gap is defined as the difference between measured serum osmolality, abbreviated as SO, and calculated serum osmolality using equation below. Calculated serum osmolality, in milliosmoles per kilogram is equal to 2 multiplied by sodium levels in milliequivalents per liter plus glucose levels in milligrams per deciliter, all divided by 18, plus the BUN in milligrams per deciliter divided by 2.8 when the difference between measured and calculated serum osmolality is greater than 10 milliosmoles per kilogram. The presence of an unmeasured osmotically active substance, such as ethanol, methanol, or ethylene glycol, should be considered. G.D.Y's calculated serum osmolality is 295 milliosmoles per kilogram, compared with the measured value of 332. Therefore, his osmolal gap is 37 milliosmoles per kilogram. An increase in the anion gap and osmolal gap, without diabetic ketoacidosis or chronic renal failure, suggests the possibility of metabolic acidosis resulting from a toxic ingestion. On the basis of G.D.Y's presentation, papilledema, history of alcohol abuse, increased osmolal gap, increased anion gap, metabolic acidosis, history of dementia, and partially empty bottle of windshield wiper fluid found at the scene, methanol intoxication should be considered. The next question reads, how would G.D.Y's methanol intake induce metabolic acidosis with an elevated anion gap? Methanol intoxication results in the formation of two organic acids, formic and lactic acids, which consume bicarbonate with production of an anion gap metabolic acidosis. Alcohol dehydrogenase in the liver metabolizes methanol to formaldehyde and then to formic acid. The formic acid contributes to the metabolic acidosis and also is responsible for the retinal edema and blindness associated with methanol intoxication. Serum lactic acid concentrations also are increased in patients with methanol intoxication. Lactic acidosis classically has been divided into type A, which is associated with inadequate delivery of oxygen to the tissue, and type B, which is associated with defective oxygen utilization at the mitochondrial level. Although these distinctions often are not clear, the lactic acidosis caused by methanol intoxication is most consistent with the type B variety. The next question reads, how should G.D.Y's methanol intoxication be managed acutely? Let's now discuss antidotes. Because G.D.Y's mental status is impaired and his respiratory rate is 40 breaths per minute, his airway was secured via endotracheal intubation and he was placed on mechanical ventilatory support. Even though both ethanol and fomepizole compete with methanol for alcohol dehydrogenase binding sites and could be used to treat G.D.Y, fomepizole is chosen because it is easier to dose and does not need serum level monitoring to ensure efficacy like ethanol. Because ethanol and fomepizole have much greater affinity for alcohol dehydrogenase than methanol, these agents may reduce the conversion of methanol to its toxic metabolite, formic acid. The unmetabolized methanol is then excreted by the lungs and kidneys. Fomepizole can be given IV as a 15 mg per kilogram loading dose for 30 minutes, followed by bolus doses of 10 mg per kilogram every 12 hours. Because of induction of metabolism of fomepizole, doses should be increased to 15 mg per kilogram every 12 hours if therapy is required beyond 2 days. Fomepizole is usually continued until the serum methanol concentration is less than 20 mg per deciliter, corresponding to 6.2 millimoles per liter. Adverse effects of fomepizole are relatively mild. G.D.Y should be monitored for headache, nausea, dizziness, agitation, metallic taste, abnormal smell, and rash. Cofactor therapy with folinic acid or folic acid at a dosage of 50 mg IV every 6 hours should be given to enhance the elimination of formate along with IV thiamine because of G.D.Y's history of chronic alcoholism. Because of its high cost and infrequent use, some hospitals might not have fomepizole readily available. In such cases, ethanol is an alternative. Administration of IV ethanol as an antidote can be technically difficult and may produce central nervous system (CNS) depression. For G.D.Y, an IV loading dose of 0.6 gram per kilogram ethanol solution should be administered over the course of 30 minutes, followed by a continuous infusion of about 150 mg per kilogram per hour if the patient has been drinking, or 70 mg per kilogram per hour for non-drinkers if the patient was not drinking. Serum ethanol concentration should be maintained at more than 100 mg per deciliter. Charcoal may be considered to bind other agents that may be co-ingested. When other low molecular weight toxins, such as ethanol or ethylene glycol, are not present, the serum methanol level can be estimated by multiplying the patient's osmolar gap by a standardized conversion factor of 2.6. G.D.Y's osmolar gap of 37 milliosmoles per liter, therefore, may reflect a methanol level of approximately 96 mg per deciliter, 37 milliosmoles per liter multiplied by 2.6. When methanol blood levels are higher than 50 mg per deciliter, hemodialysis is indicated to rapidly reduce concentrations of methanol and its toxic metabolite. The dosage of fomepizole or ethanol should be increased in patients receiving hemodialysis to account for the increased elimination of these antidotes. Ethylene glycol poisoning can also be treated by using fomepizole or ethanol. Bicarbonate in general, a severe acidosis causes reduced myocardial contractility, impaired response to catecholamines, and impaired oxygen delivery to tissues as a result of 2,3-diphosphoglycerate depletion. For this reason, some clinicians have judiciously administered IV sodium bicarbonate to patients with metabolic acidosis in an attempt to raise the arterial pH to about 7.20. In G.D.Y's case, bicarbonate therapy is indicated in an attempt to raise the pH to 7.3, which converts formic acid, unionized metabolite of methanol, to formate, ionized form, to decrease tissue penetration. If IV sodium bicarbonate is given, the amount required to correct serum bicarbonate and arterial pH can be estimated using equation below. Bicarbonate dose, in milliequivalents, is equal to 0.5, in liters per kilogram, multiplied by body weight, in kilogram, multiplied by the desired increase in serum bicarbonate, in milliequivalents per liter. Bicarbonate distributes to approximately 50% of total body weight. Thus, the factor of 0.5 liter per kilogram in the equation above. To prevent overtreating, bicarbonate doses should only attempt to increase the bicarbonate concentration by 4 to 8 milliequivalents per liter. For G.D.Y, the dose required to raise serum bicarbonate from 8 to 12 milliequivalents per liter amounts to 120 milliequivalents of bicarbonate, that is 0.5 liter per kilogram multiplied by 60 kilograms multiplied by 4 milliequivalents per liter. Equation above. Clinical assessment of the effect of bicarbonate can be determined about 30 minutes after administration. Arterial pH and serum bicarbonate concentrations should be obtained before any additional therapy. The next question reads, what are the risks of G.D.Y bicarbonate therapy? Concerns about the risks of bicarbonate administration and the failure of studies to demonstrate significant short-term benefits have raised questions about the appropriateness of bicarbonate therapy in metabolic acidosis, particularly in ketoacidosis and lactic acidosis caused by cardiac arrest or other hypoxic events. Bicarbonate administration can result in over-alkalinization and a paradoxical transient intracellular acidosis. Whereas arterial pH can increase rapidly after bicarbonate administration, intracellular pH increases more slowly because of slow penetration of the negatively charged bicarbonate ion across cell membranes. The bicarbonate in plasma, however, is converted rapidly to carbonic acid, and the carbon dioxide tension increases as a result. Because carbon dioxide diffuses into cells more rapidly than bicarbonate, the intracellular bicarbonate to carbon dioxide ratio decreases, resulting in a decrease in intracellular pH. This intracellular acidosis will persist as long as bicarbonate administration exceeds the carbon dioxide excretion. Therefore, adequate tissue perfusion and ventilation must be provided in patients with diminished carbon dioxide excretion, e.g., cardiac or respiratory failure. Over-alkalinization also will cause a shift to the left in the oxygen-hemoglobin dissociation curve. This shift increases hemoglobin affinity for oxygen, decreases oxygen delivery to tissues, and potentially increases lactic acid production and accumulation. Sodium bicarbonate administration also can cause hyponatremia, hyperosmolality, and volume overload. However, the excessive sodium and water retention usually can be avoided by the administration of loop diuretics. Hyperkalemia is another potential adverse effect of bicarbonate therapy. Acidosis stimulates movement of potassium from intracellular to extracellular fluid in exchange for hydrogen ions. When acidosis is corrected, potassium ions move intracellularly, and hyperkalemia can occur. This translocation of potassium tends to reduce serum potassium levels by about 0.4 to 0.6 milliequivalents per liter for each 0.1 unit increase in pH, although wide interpatient variability in this relationship exists. In G.D.Y and other patients with organic acid intoxications, raising extracellular pH helps to provide a gradient to shift the toxin from the CNS and trap it into the blood and urine, thus enhancing elimination. To prevent the risks of bicarbonate therapy, G.D.Y's mental status, serum sodium and potassium levels, and ABG should be monitored. The next case reads, S.T.J, a 75-year-old, 60-kilogram woman, was admitted to the hospital 4 days ago with peripheral edema and pulmonary congestion consistent with a congestive heart failure exacerbation. Since admission, she has been treated aggressively with furosemide 80 to 120 mg IV daily, which has generated approximately 3 liters of urine output each day. Today her lung sounds are clear and peripheral edema shows considerable improvement with diuresis. However, she now complains of dizziness when she gets out of bed to go to the bathroom. Physical examination reveals a tachycardic, that is a heart rate of 100 beats per minute, thin elderly woman with poor skin turgor and slight muscle weakness. S.T.J's electrocardiogram shows flattened T waves and U waves. Laboratory tests reveal the following: serum sodium levels of 138 milliequivalents per liter, potassium levels of 2.5 milliequivalents per liter, chloride levels of 92 milliequivalents per liter, creatinine of 0.9 mg per deciliter, a BUN of 28 mg per deciliter, a pH of 7.49, a partial pressure of carbon dioxide of 46 mm of mercury. Bicarbonate of 34 milliequivalents per liter. Urine chloride concentration is 60 milliequivalents per liter. So my question to you reads, what acid-base disorder is present in S.T.J? Using the stepwise approach to the evaluation of acid-base disorders as previously described, S.T.J's elevated pH is consistent with alkalosis. Furosemide-induced diuresis may be a clue to her acid-base disorder. The increased serum bicarbonate and increased partial pressure of carbon dioxide suggest primary metabolic alkalosis with respiratory compensation. S.T.J's anion gap is 12, suggesting no additional metabolic acid-base abnormalities are present. A partial pressure of carbon dioxide of 46 mm Hg suggests normal respiratory compensation for metabolic alkalosis. Appropriate treatment of the metabolic alkalosis should return her partial pressure of carbon dioxide to normal if there is no underlying pulmonary disease. The next question reads, what is the most likely cause of S.T.J's acid-base imbalance? The hyperkalemic, hypochloremic, metabolic alkalosis in S.T.J most likely is the result of diuretic-induced volume contraction. The incidence of this adverse effect is influenced by the type, dose, and dosing frequency of the diuretic. Diuretics cause metabolic alkalosis, sometimes referred to as a contraction alkalosis, by the following mechanisms. First, they enhance excretion of sodium chloride and water, resulting in extracellular volume contraction. Volume contraction alone will cause only a modest increase in plasma bicarbonate. However, volume contraction also stimulates aldosterone release. Aldosterone increases distal tubular sodium reabsorption and induces hydrogen ion and potassium secretion, resulting in alkalosis and hyperkalemia. In addition, hyperkalemia induced by diuretics will stimulate intracellular movement of hydrogen ions to replace cellular potassium, producing extracellular alkalosis. Hypochloremia also is important in sustaining metabolic alkalosis. In a hypochloremic state, sodium will be reabsorbed, accompanied by bicarbonate generated by secreted hydrogen. The next question reads, how should S.T.J's acid-base imbalance be corrected and monitored? Treatment of metabolic alkalosis depends on removal of the cause. S.T.J's diuretic therapy should be temporarily discontinued until her volume status and electrolytes can be restored. The initial goal is to correct fluid deficits and replace chloride and potassium by infusing sodium and potassium chloride. As long as hypochloremia exists, renal bicarbonate excretion will not occur and the alkalosis will not be corrected. The severity of alkalosis dictates how rapidly fluid and electrolytes should be administered. In patients with hepatic or renal failure or congestive heart failure, infusion of large volumes of sodium and potassium salts can produce fluid overload or hyperkalemia. Thus, fluid and electrolyte replacement should proceed cautiously, and these patients should be monitored closely for these complications. Potassium chloride should be administered to correct S.T.J's hyperkalemia. The amount of potassium required to replace total body stores is difficult to determine accurately because 98% of the potassium in the body is intracellular. Although wide variation exists, for each 1 milliequivalent per liter decrease in potassium from an ECF concentration of 4 milliequivalents per liter, the total body potassium deficit is about 4 to 5 milliequivalents per kilogram. S.T.J's serum potassium is 2.5 milliequivalents per liter, which correlates with a decrease of about 350 milliequivalents in total body potassium stores. S.T.J should be treated with the chloride salt to ensure potassium retention and correction of alkalosis. Potassium replacement can be achieved over the course of several days with supplements of 100 to 150 milliequivalents per day, given either orally in divided doses or as a constant IV infusion. S.T.J's laboratory tests for BUN, creatinine, chloride, sodium, and potassium should be monitored during sodium and potassium chloride therapy. As noted earlier, hypercapnia should disappear after correction of the alkalemia, and can be confirmed with an ABG, if clinically indicated. My next question to you reads, what other agents are available to treat S.T.J's alkalosis if fluid and electrolyte replacement does not correct the arterial pH? Patients unresponsive to sodium and potassium chloride therapy or those at risk for complications with these agents can be treated with acetazolamide, hydrochloric acid, or a hydrochloric acid precursor. The most commonly used agent is acetazolamide, a carbonic anhydrase inhibitor that blocks hydrogen ion secretion in the renal tubule, resulting in increased excretion of sodium and bicarbonate. Although the serum bicarbonate concentration often improves with acetazolamide, metabolic alkalosis may not completely resolve. Other concerns with the use of acetazolamide include its ability to promote kaliuresis and its relative lack of effect in patients with renal dysfunction. A solution of 0.1 N-hydrochloric acid may be administered to patients who require rapid correction of alkalemia. The dose of hydrochloric acid is based on the bicarbonate excess using equation below, where the factor 0.5 multiplied by body weight, in kilograms, represents the estimated bicarbonate space. Dose of hydrochloric acid, in milliequivalents, is equal to 0.5 multiplied by body weight, in kilograms, multiplied by plasma bicarbonate minus 24. Parenteral hydrochloric acid is prepared extemporaneously by adding the appropriate amount of 1N hydrochloric acid through a 0.22 micrometers filter into a glass bottle containing 5% dextrose or normal saline. The dilute solution should be administered through a central venous catheter in the superior vena cava to reduce the risk of extravasation and tissue damage. The infusion rate should not exceed 0.2 milliequivalent per kilogram per hour. ABG should be monitored at least every 4 hours during the infusion. Hydrochloric acid should not be added to parenteral nutrition solutions. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 366.